Well, good morning, everybody, and welcome to our DDSI Virtual Grand Rounds broadcast. I'm Scott Steele, the Chairman of Colorectal Surgery here at the Cleveland Clinic, and welcome to beautiful Cleveland, Ohio. I'm very pleased today to introduce today's presenter, Dr. Sarah Vogler, who is our section chief of the pelvic floor section within DDSI within the Department of Colorectal Surgery. And today we're going to talk about a topic that is maybe one that doesn't get enough press, if you will, and that's fecal incontinence. And that's something that a lot of our patients may suffer from, but it's something that they may be a little bit embarrassed to even bring up to their own spouses, their own family members, and as well as their own doctors. And so we're going to walk you through the evaluation and the management of this, and I'm very pleased. Registrants from over 35 countries, as you can see here, from all around the world, taking time out of your morning, afternoon, or evening to join us here. And I encourage everybody to really, this is an interactive session. And so you can see right here that we do have the chat box, and within that chat box, I got it right in front of me, and we will do everything we can to answer your questions. I'll go over a little bit of some things regarding the CME at the end. But for that, I'd like to turn it over to Dr. Vogler. Sarah, thanks so much for joining us here on our Grand Rounds.
Yes, thanks for having me. So we're going to look at fecal incontinence treating structure and function. Just a brief outline, starting with background of fecal incontinence, then looking at some newer treatment algorithms, pelvic floor physiology testing and how that works its way in, and then the surgical treatment options for fecal incontinence. So a brief background, fecal incontinence is the involuntary loss of gas, liquid, or solid stool through the anal canal. It's certainly not a life-threatening problem, but it's definitely life-altering for these patients. 18 million adults suffer from fecal incontinence, which is roughly the population of Florida. Not that everybody in Florida is incontinent, but it's a lot of people. 2.2% of the US, 50% of those patients who are in nursing homes. So this is an overview of the treatment algorithm. The part on the left in the green, we're not going to focus quite as much on. That's the initial medical workup and evaluation. And the part on the right is more of the surgical treatment algorithm. So certainly, like Scott said, these patients are difficult to find, not because they're not seeing you in clinic, but sometimes because they won't admit to it or they don't know how to bring it up. So the first part is identifying the patient and then doing an initial clinical assessment of history and physical, medications and diet, assessing how much this impacts their quality of life. So if it happened once after they went out to eat somewhere and it's never happened again, probably not going to worry about it as much as somebody who it's happening daily. And then obviously colonoscopy and typical medical evaluation. So the easily reversible things that are not going to require any type of surgical evaluation, or if you can pinpoint medications, diet, if they're having just diarrhea and you need to treat that. And then you're going to move over more into the surgical treatment. If they're having form stools, at least 2 episodes a week, or daily urgency, meaning that they're trying to rush to the bathroom, and they had no relief with trying simple over-the-counter bowel regimen medications. In that case, they're probably going to go on for a more specialized assessment, which is when I see patients. So when they first present, this is somewhat of the typical history, maybe not a whole lot of information. They don't quite know when it started. They don't know if it's associated with urinary urgency, incontinence or not, and they think it just happens most days. Basically, they're just mortified it's happening, and there's not a whole lot of objective data that they give. And as you ask these questions, they're also then looking at their husband who's like, I don't know, I don't even know why I'm here, and I don't want to be here. So you don't get a lot of facts. And honestly, on exam, a lot of these patients it's more the 50 to 70-year-old age category, and everything might pretty much look normal. So that's why pelvic floor physiology testing will help give some more objective data to what's happening in their pelvis and their strength. What test does this include? So this can include endoanal ultrasound, anal rectal manometry and EMG, and defecography. Ultrasound's mainly going to look at the structure. This is probably more helpful in younger patients right after some sort of obstetrical injury. And then anal manometry EMG is looking at strength. So how strong are the anal sphincter muscles and what do the pelvic floor muscles do? How well do they coordinate? And then defecography is more of a dynamic study, not something everybody really wants to sign up to do, but it's incredibly helpful, and we'll look at that. The common question is, do you really need to do this? Is this testing necessary? And I would say it's very helpful. The anal manometry and EMG is the fastest and easiest. You can do it in clinic, takes about as long as a digital rectal exam and comprehensive exam. And defecography, although it's not overly fun for the patient, it is painless, and it helps you see what you can't just see with your naked eye going on in the pelvis. So once we've worked through the testing is when you're going to start to try and figure out which category do they fall into. And of these pathways, we're going to look mostly at the top two. So the bottom two, the overflow fecal incontinence, is more of a constipation pattern. And then if they're severely debilitated or spinal cord injuries, those are going to fall into a separate treatment option. So if we take the patient that's a good surgical candidate, they have good fitness, and they're more than 10 years out from childbirth. So this is probably going to exclude those patients that have, say, a rectovaginal fistula or cloaca, something anatomical that would have been caught earlier. This is probably the 50 to 70 or 80-year-old category. Starting with a physical exam, then testing of defecography and manometry. So the big grouping then is going to be, is there prolapse or is there not prolapse? And we'll look at that more carefully, but that doesn't just mean can you see prolapse, because there still may be some internal prolapse. But let's say their defecography does not show any prolapse. So they're going to fall into one of the two on the left side. No prolapse. They have normal or high sphincter strength on manometry. And there's really nothing that can be surgically fixed, right? They have good strength. They don't have a prolapse. So they're going to fall more into the pelvic floor physical therapy, biofeedback, bowel regimen, just try to get things working better because everything's already there. So now let's look at those patients that have a weak sphincter. Maybe this was a childbirth injury or pelvic radiation or something else that caused their sphincter to weaken. There's three options here: inserts, sacral neuromodulation, or anal sphincteroplasty. So the quick and easy is that inserts and injectables buy time, but as you look at these, some of them are almost comical. Sacral neuromodulation is probably the latest and the greatest, and anal sphincteroplasty for this category of patients is not favored as much. So I definitely hear this in clinic. They all want the easy fix, and that a lot of patients have just said, do you just have a plug for me? This is actually a plug that's available. It's called the Renew Anal Insert. If you look at it, it's probably smaller than your pinky finger, and when I've shown this to patients, they just laugh. But some of them will try it, so this could buy some time. There was a study that looked at this, obviously a single-arm study. Patients had to have at least weekly fecal incontinence, and they used these plugs for 12 weeks. They went through about 2 to 3 plugs a day. There was easy loss of the insert if they had a bowel movement, urination, or passing gas. But 50% of those thought that there is, or 62% actually thought that they had a reduction in their fecal incontinence episodes. Very few adverse events, certainly none that would be horrible to deal with, such as sensation of urge, displacement within the rectum, or irritation and pain. So those patients that did complete thought that it was helpful. I would say of the patients that do this, though, maybe 2 to 3 weeks, and then they get tired of it. So this is something, again, that's just going to buy you some time. The Eclipse vaginal bowel control system, this is a little bit more difficult, I guess, to have a patient start. The Renew Anal Inserts you can just order, but this you have to have the patient fitted, and then they do a 2-week trial of a disposable one. And the fitting is not as easy as it might seem. It's more of a vaginal exam to determine the fitting, and that's where patients can have discomfort. So 55% of the patients in this trial were fitted and were able to enter, but that is about what I've noticed too, is about 50% of patients can tolerate it, and the other 50% we just can't get them fitted so that it's comfortable. So in looking at this trial too, there was improvement. They successfully decreased their episodes of fecal incontinence, and they had improvement in their quality of life metrics. All of those things happened pretty much immediately and then plateaued, so there was an ongoing improvement, but they maintained over the course of 1 year. You just have to keep in mind that, again, it's kind of a 50-50 for patients who are able to tolerate this. And if this has this little tubing that you have to inflate and deflate, so it does require the patient to be able to do that daily, which I also think is another problem with long-term use. This study looked at what type of incontinence it will work on. And across the board, it did pretty well. So liquid stool urgency and incomplete evacuation saw an improvement from baseline at 1 month. So again, it's a good option, but probably not when people use long-term. And then Celesta. Celesta's kind of been on the market, off the market, somewhat difficult to get. It was approved by the FDA in 2011, and it's an injectable hyaluronic gel. In some ways, it looks like you're giving patients hemorrhoids, which is not exactly what's happening, but it's an injection into the anal canal in the vicinity of the hemorrhoidal columns. So you inject this in the submucosal area to bulk the tissue up in that area and hopefully increase their overall resting anal pressure. You can do this in the office without anesthesia, and it comes in a package with the 4 injectable syringes. How has this worked? You have to read this data carefully. It did show that it had an improvement in fecal incontinence in 53% of patients. But when you compared that to the sham group also had 30% improvement in fecal incontinence. So the real difference there is not a lot between sham and the Celesta. Those patients who were injected saw a decrease in fecal incontinence episodes from 15 in 2 weeks down to 8, and then they sustained that over 3 years. This was a little bit vague as to how many times you inject these patients, so at least half of these patients had 2 rounds of injections.
So this may be a good time to stop and answer a couple of questions that have come up. One of the questions that one of the attendees asks is, how do you define success? And just based on even that last Celesta trial and the time before, so what can patients expect with some of these things? Is success, is it free of having any leakage at all, or an improvement, or what is that all about? And how, as we go through some of these different data here, how are we as providers supposed to not only interpret the data, but also then to convey that expectations to our patients?
Mm-hmm. So I think that last thing you said is probably the key, the expectations for patients, especially on these inserts and injectables, because they do have to understand that it requires something on their part every day for the inserts. And a lot of patients are looking for kind of the treatment option where they don't have to do anything, they're just better, right? The incontinence is gone. And I would say in that first category of inserts and injectables, it's not going to be 100% gone, and it's going to require some effort on their part. So that probably is where they kind of move down the treatment algorithm and they get tired of doing those things every day. But yeah, I have had some patients that, they just want better control, say when they're out running, or they want better control because it's really bad in the morning. And so if they have a certain expectation and you can meet that expectation with these easy things, then that's great. But every patient's different on what they want to achieve.
And I had one of our attendees write in, and I don't know if they're saying that they had prolapse incontinence or what, but they said they just had a patient that just rolls up a sock and just kind of pushes thing in. I'm guessing maybe that's prolapse or not, but along the lines of the kind of the plug that you talked about, is there any data to support something like that?
So I think for some reason all patients really want this like butt plug that they don't have to think about, but there's nothing really bigger than that anal insert. Okay. Clearly in prolapse, that's going to fall out. I mean, I've read stuff on some of these chats where on the vaginal side, they'll use ping pong balls. I mean, I think patients have gotten incredibly creative and will use whatever they need to, but most of that is a prolapse correction. So along the line of a pessary too. Those are things that you're going to insert to try and correct anatomy. And we don't have a great insert for rectal prolapse cures by any means. So let's look at anal sphincteroplasty. I think that's what patients still come in thinking, I'm going to have my sphincter fixed and then I'm going to be continent. And you have to be careful when you look at this data, because certainly in patients that had an obstetrical injury and within a couple years they have a rectovaginal fistula or they have a big cloaca, or there's some structural abnormality that's immediately present after childbirth, then this is probably your treatment of choice because you're going to fix anatomy. But in patients who come in and they are now incontinent, but their oldest child is in their 30s, going back and fixing that injury they sustained 20, 30 years ago is probably not going to make their incontinence better. So this is a very invasive procedure. You go in, you find the muscle bodies that have probably split apart, and you then pull those together and sew them together as overlapping sphincter repair. But there's lots and lots of data on this. This has been around for a while, but this is a really big meta-analysis looking at several of these trials. So 16 studies, 900 patients, and all of them showed that there's a decay in functional outcomes. So a lot of these patients, especially in the age category of 50 to 80, they don't really necessarily care what it looks like. They want to be able to leave their house every day. So that's what they care about, is their function. When you look at how these studies graphed out, there's one that shows that maybe there was function maintained over the course of about 2 years, and everything else shows a decline. So this is one, if you're setting expectations, your anatomy might be repaired, but your function is probably not going to improve, and you're going to go back to your baseline.
So just based on this, looking at the Halverson study right there, which is the Cleveland Clinic study, when you follow these patients out over 5 years, there's very, very few people that actually have sustainable full continence.
Mm-hmm.
You know, is that liquid? Is it solid? Is it gas? Were you able to kind of delineate those type of things?
So it's a little bit tricky, again, reading this, because once sacral nerve stimulation came out, it became the definition is greater than 50% improvement in incontinence. And some of these studies have looked at that. Some of them have just gone based on a severity index. Some have looked at a Wexner score, so frequency and pad use. But depending on what validated score they use, there was a decline. It's just not the same across the board for the study.
Okay.
So when you look at sphincteroplasty in this category of patients, yes, it's going to restore anatomy. I don't know that that's always their primary function, honestly. But the disadvantage is it's going to be an invasive surgery with a post-op recovery. The wound breakdown rate's pretty darn high. So they're going to have a wound they kind of have to nurse along for several weeks. And then, as we said, the functional results are marginal and probably not sustained. So let's go to the latest and greatest. Sacral neuromodulation, this was FDA approved in 2011. When I describe this to patients, I kind of describe it as the pacemaker for the butt. They look at me like I'm crazy, but these are really happy patients, honestly. So what it is a small lead that you put through a sacral foramen, and that tip of that lead lives down where the nerves are that kind of innervate and control bowel and bladder function. It's the exact same procedure if you're doing this for urinary incontinence as if you're doing it for bowel incontinence. And that lead's going to live there, and it's connected up to a battery then. That battery life will vary, but it's somewhere between 5 and 10 years. We actually have rechargeable batteries now. So the nice thing when they look at me like I'm crazy and just told them I should implant something to improve their incontinence is that I can say, well, we can kind of just put your toe in the water and test it first. So you get to do a test phase where I commonly do this part just as a clinic procedure where we put little temporary leads in. They wear those leads for a week and they see if they have an improvement in fecal incontinence. Although the insurance requirement is a greater than 50% improvement, I tend to go by, do the patients really say it's better? Because most patients will come back and say, this is markedly better. I can't live without it. And the patients that kind of come back and are like, I don't really know. You know, sometimes they'll go on to implant, but for the most part, we kind of look for other reasons that maybe we're missing something. So after they've done their test phase, if they like it, they can go on to permanent implantation. There's now 2 devices on the market. So Medtronic was the original device that was FDA approved in 2011 and is still available. And then Axonics is a newer one. They work slightly differently, so you have to know which device you're implanting as far as what the clinician has control over doing. Both have come to the point where they're MRI compatible, they're rechargeable, they're about the size of a quarter, so they're very small. Patients will know where they are, where the incision is, they can feel it, but nobody else would be able to look at them and think, oh, they have something under their skin there. So how well does this work? When you look at sacral neuromodulation versus just optimal medical therapy, at baseline, these patients have about 9 episodes of fecal incontinence a week, and after sacral neuromodulation, it dropped to 3 episodes a week, which was a drastic improvement. Long-term improvement, if you look at this, you want to kind of combine the blue and the red because blue and red is considered improvement. Blue is considered 100% improvement. So immediately after implantation, this bounced up to 90% of patients considering a clinical success. So that's better than almost anything we have out there to treat fecal incontinence. Quality of life increased immediately and then continued to sustain an improvement across all 4 parts of the scale with slight increase over time. And then pad use, which is something that patients are very stuck on. It's interesting that they hold on to using pads for quite a bit of time, and I think it's kind of a security blanket type of thing, not because they're having to change it. So if you actually look at how many pads per day were used, that's a sharp drop off compared to what it was pre-sacral neuromodulation. If you look at how many continue to use a pad, they tend to continue to use pads for several years, but for the most part, they'll trend away from it. How does it work? That's kind of the common thing everybody asks, and the short answer is we really have no idea. They've looked at what parts of the brain light up in MRI, and initially the frontal part lights up, and then in the long term, they kind of continue in the caudate in the learning and rewarding process. But we don't have a great understanding of this, I would say. These patients are by far my happiest patients. They always come bearing gifts at their post-op visit, so it has changed their lives. These people go from being incontinent and not wanting to leave their house to, oh my gosh, I can do whatever I want now. So it is fun to see them back. So those are your 3 categories of treatments that you have if they have no obvious prolapse, but they're weak. So then what about prolapse? Why not just give them sacral neuromodulation? Because that's easy, outpatient surgery. Well, when you look at this, there is no way one of those little stimulators is going to make that better, right? So obviously, full thickness prolapse of any type is an anatomic defect. You have to fix it. But this is where we get tripped up. And initially, we were doing sacral neuromodulation on almost everybody who came in with this seepage and incontinence, and it wasn't working all the time. And I think this is what we were missing, and this is what the literature is starting to show, is this rectal intussusception. So you can't see prolapse falling out, but there are things collapsing in their pelvis. And one of the most common symptoms they're going to present with is incontinence, or a combination of incontinence and kind of this obstructive evacuation pattern. And they get that incontinence and seepage because everything collapsed when they try to evacuate, and then it plugs themselves up. And then when they kind of get up from going to the bathroom, things work their way back into normal place, they start to seep out stool. So this rectal intussusception, as it gets worse and worse, it could start as just a short intussusception and move on. There is worsening severity of fecal incontinence. So in patients who do seek care for this, they're probably already in the category of a deeper rectal intussusception. And then with time, they have decrease in their anal tone and strain. So how does sacral neuromodulation work for these patients? This has actually been looked at, and it's very interesting data. So patients with no intussusception had a very high success for P&E. I would consider 86% to be pretty much I'd expect across the board, all comers. So no intussusception, they were standard. They had 86% success, and they had a high improvement in severity. And all of those patients had a quality of life improvement. But patients who had rectal intussusception, their success with the P&E, it was still there. 69% is not bad. Sometimes wonder how much is a placebo effect. But they really didn't see a good improvement in their severity of symptoms, and they saw no improvement in quality of life. So that just becomes a treatment that you gave the patient, and they keep coming back, and you're reprogramming, and you're trying to make it work, and it's just not working. So why not? So this is defecography. This is the helpful part because you can't see through the patient to see what's falling down, but it's a dynamic study with contrast in the rectum and the vagina, and then they evacuate it so you can see what falls down. If you look at this before and after, the after on the left shows that they've had their bladder kind of do this back bend down into their pelvis. The vaginal silhouette has been completely obliterated by a big enteroceal, and then their rectum has an intussuscepted and collapsed down. That's not visible on the outside, so you're just not going to see anything. But on the inside, it's going to be really hard to expect them to have normal bowel and bladder function with all that happening. So these people fall into a prolapse repair category. That's why you want to distinguish if they have prolapse or not, because they're going to go on for surgical repair. What are the options? There's hundreds of options to treat rectal prolapse. For internal intussusception, you really want to direct your repair at fixing what's falling down. And most of these patients, if you think back to the stephicography, that was a big enteroceal and an intussusception that probably started after a rectoceal. So you want to try and support the front of the rectum, right? The tailbone didn't cause all that stuff to fall down. That was all falling kind of from the front and middle. So that's why ventral rectopexy has gained a lot more momentum, I think, recently, because it's doing a good job of improving the function. And what a ventral rectopexy is, a pure, just pure ventral rectopexy, no sacral colpopexy, is the picture on the right, where you put mesh along the anterior rectum, up to the posterior vagina, and then up to the promontory. And the picture on the left shows it combined with a sacral colpopexy, which is incredibly easy to do if you're going to help the patient. So what's the function after doing a prolapse repair? For external rectal prolapse, they see up to a 90% improvement in fecal incontinence. And then for the internal rectal prolapse, they're still seeing up to a 90% improvement in fecal incontinence. And this is what I've seen too in my practice. So I was doing a lot of sacral nerve stimulation. That's once I started looking for this intussusception, I was fixing the intussusception, and I've never had to go back and do a sacral nerve stimulation on the patients I've done a ventral rectopexy on. Most of this data is out of Europe. They were doing this long before we were in the United States, but this also shows that improvement in incontinence was high. So it ranges between 70 to 90%, and all of these were using the Physi score, the St. Mark's score, so validated scores to look at severity and quality of life with fecal incontinence. It also improves obstructive defecation, which can play into symptoms of fecal incontinence. These are some pictures from doing the procedure. I tend to do it robotically. It can be done laparoscopically. Patients shouldn't worry about this. I think that's the biggest thing is they say, well, just give me a plug or just give me the easy procedure, because they don't want to think they have to go in for major surgery. And it is major abdominal surgery as far as what it's categorized as, but they do really well. They typically spend 23 hours in the hospital. They go home the next day. They have their 5 little incisions. Most don't take any narcotics, and they're kind of back to putzing around their house and going shopping within a couple weeks. So that kind of, fills out your surgical treatment options in this algorithm. So in summary, you're going to start with the easy treatments that you don't have to do any testing for: diet, medications, exercise. If they have persistent fecal incontinence, that's going to probably deserve further evaluation, pelvic floor testing to get some objective data. And the surgical treatment options that we have now are very easy and also very effective. Thanks.
Well, Sarah, that was fantastic, and thank you so much for walking people through. And just a reminder, if you can use the chat line, you can chat to everybody, or as some of you have done, you can just put your questions directly to me on the chat line. So, Sarah, lots of things, lots of questions to go through, and glad we got a little bit of time, but please continue to get your questions in. First one is that how do you tell the difference between seepage and true fecal incontinence when you're taking a history on your patient? There seems to be some question, and maybe I'm guessing what they're talking about is, how do you know when it's so bad that you're going to go down this route, or you just give them some bulking medications and say, you might have a little bit of occasional streaks or something like that? How do you make that determination?
Well, the patient will pretty much tell you if they're having full accidents or if they're just having a seepage that they can wear a pad for. And then it's like you said, you probably are going to just start with fiber or Imodium. Why not try the easy stuff first? And if it gets better and it goes away, then you're not going to have to do anything else. I would say a lot of the seepage, especially mucus seepage, is something that points itself more towards the intussusception than just the frank, weak sphincter, can't hold on to a bowel movement. So seepage is something that I would consider needs to be worked up and evaluated if you can't treat it the easy way.
And if somebody has rectal prolapse in that setting, would that weigh into your kind of how you're going to go down your pathway?
Mm-hmm. Yeah, that's very common, is that patients are presenting with this, well, I have a little bit of seepage, or I'm able to go to the bathroom, have a normal bowel movement, and then for some reason, after I have a bowel movement, I have seepage. And they're incredibly perplexed when that's happening. But that is a telltale sign that they're having this incomplete evacuation for some reason.
Another question is talking about multi-component, I'm assuming defects or prolapse in this case. But I guess what they're asking is, how do you make a determination of when to fix one, when to fix them all? If I fix one compartment, will that mean the other compartment will get worse? Does everything have to be combined? And another question that came up said, I'm only a colorectal surgeon. We don't have urogynecology. If they have multi-component urinary and fecal incontinence, can I just fix one, or do they have to get combined together?
Yeah, so I think you have to know what your resources are, first of all. And I also think it's going to just help the patient and you if you know what is involved in that. Because as we know, patients are going to be perfection seeking in their habits. So as soon as you make one thing better, then even though they may be saying, oh, I don't care about my urinary incontinence, the minute they don't have fecal incontinence anymore, that tends to become like the next hurdle that they're going to try to tackle. So in general, I would say treat the pelvis as a whole. And I think with the ways we have, surgical treatment these days, certainly sacral nerve stimulation treats urinary and fecal incontinence. So I want to know if they're having both. I may not send them to urogynecology if I'm going to treat their fecal incontinence that way. It's going to kind of be a side effect bonus if their urinary gets better. But when I look for prolapse, if I see that multi-compartment prolapse happening, and certainly if they have any symptoms of urinary incontinence, urgency, vaginal pressure, bulging, then I think it's only going to help my repair to get urogynecology involved, right? Because I know I can only fix so much. And if part of the problem is all of these other things are collapsing on top of what would be my rectal repair, then I just think my rectal repair is going to break down. It's gonna last maybe a few years, and they're gonna have some persistent symptoms. So that's where I think it's in the patient's best interest to have a multidisciplinary evaluation and treatment plan.
Another question came up about non-operative options. Are these just a waste of time, or should I just go right to sacral nerve modulation, or how often does they really work? And I'm assuming they're maybe throwing in bulking agents and just dietary changes into that as well.
Well, you definitely need to start with the easy dietary things first, because patients who are mainly having this urgency and leakage because they're having loose stools, diarrhea, sacral nerve stimulation or prolapse repair is never going to cure diarrhea. It's never going to cure loose stools. So you have to work on those things because you're going to have to keep working on them, even if you do treat them surgically. Patients tend to work at a pace sometimes where they want to try those things and they want to really prove to themselves that I want an implanted device or I want to have abdominal surgery, especially this patient population. Although they want instant relief of incontinence, they're also not willing to just dive in because it's not a life-threatening problem. So sometimes working through that pattern helps them kind of grasp how they need to be treated.
A question just came in that talked about, what do you do when SNM fails, or maybe when the patient initially had good response to SNM, then started to have the fecal incontinence a few months after that initial improvement? What's your algorithm there? Is it a device malfunction? Is there something else going on? What's your algorithm for reevaluating those patients in rectal physiology, or how do you go about that patient?
So I tend to test them up front before I do sacral nerve stimulation and rule out prolapse. If someone were to come to me with sacral nerve stimulation and it worked and then it doesn't and they haven't been looked at for prolapse, I would look for that first because I know any amount of reprogramming is never going to fix their internal prolapse. But the nice thing about sacral nerve stimulation is you can reprogram that so many different ways to try and recapture their symptoms that if it works initially and there's no anatomic defect, then I keep reprogramming to try and recapture. And there can also be a little risk of lead movement, or you may have to re-implant them. That's very uncommon. I would say most of the time you can reprogram, recapture, and their incontinence will resolve.
So let me play devil's advocate and just say you reprogrammed till the cows came home. You put it on every single setting that has ever existed in mankind, and they still have incontinence. Is colostomy the next thing, or What are any other options as of right now?
Yeah, I would say I definitely would retest them and make sure, okay, maybe something changed in their anatomy, and really start from scratch. Colonoscopy, looking for colitis of some sort, and just start from the beginning and see what am I missing. And if I really can't find anything, including prolapse, then it's not that a colostomy is out of the question. A lot of patients will say, okay, I'd rather live with what's happening now than that, but that still is a final option.
A couple of questions now. Defecography. How do you tell what is abnormal from normal on defecography? I think what there's that famous study that talked about upwards of 30% or 35% of women will have incidental anorosile.
Mm-hmm.
So how can you tell the difference between, when something shows up and it's clinically relevant?
Mm-hmm. Yeah, because that can go both ways. So when you do defecography on normal people, you're probably going to find anatomic defects. You're going to do nothing about it. If you have a patient who has a symptom and you have defecography and you can find an anatomic defect, that's when it becomes important, but it's still a clinical judgment. So, because they could say, well, there's a small rectocele, and I've had patients who come in and they talk about their rectocele or their rectocele, or they really get hooked on that one as their main cause. And it probably is not. I would say most people who have something that's anatomically correctable don't have just one thing collapsing or looking abnormal on their defecography. They have a whole pattern of behavior on defecography, which is the flip side of that argument. So what we found is when we did defecography on people who had some sort of evacuation difficulty or incontinence problem, all of a sudden all of these other abnormalities showed up that you too still have to wonder, do I do anything about them or not? But it does tend to be a pattern of weakness in the pelvis that it helps to show.
Got a question here about ventral rectopexy, I'm guessing, and not rectocele. Speaking of rectoceles, and that, aren't you concerned about mesh in the pelvis?
I am. It was definitely slow to catch on in the United States, and I wouldn't say it's the go-to yet in the United States, because you do have to be cautious about it. So the good thing about mesh in the pelvis is that we have a really high recurrence rate in prolapse repairs. That's probably why there's 100 of them out there, because we haven't found the perfect one yet. But these patients have a lot of laxity and stretchiness in their tissue, and if you just try to pull together their tissue with time, they're probably going to go back to that stretchiness and they're going to recur. So mesh does help to give them some structure and strength. And I think the urogynecology, our partners in that have found that, right? That's why they do their repairs a lot of times with mesh or with permanent suture, or things that are going to stay there forever and ever, and not just 100% native tissue all the time. So I think that's the bonus, is you're probably going to get a stronger repair that lasts. But you do have to be careful. So if I put permanent mesh in somebody who has ulcerative colitis, I'm going to think hard and long about that, because maybe they are going to need some sort of pelvic surgery or proctectomy, where decision-making of what kind of mesh or maybe a biologic mesh is going to be important.
Yeah, and another mesh question. I don't think that the respondent is asking for a particular brand, but what type of mesh do you use? You mentioned biologic versus, polypropylene, large bore, soft. How do you put this all together for mesh in the pelvis?
So there's no FDA-approved permanent mesh for ventral rectopexy. There's some meshes that call themselves ventral rectopexy mesh, but I have not seen one that's formally FDA-approved. Sacral colpopexy mesh has gone through a lot of rigors to put some structure behind what they consider the safest mesh, lowest infection rate. And so I follow their literature. They have been putting mesh in the pelvis for years longer than we have. And so that tends to be the lightweight polypropylene mesh that I use, because that is what they use. And commonly they'll be doing the surgery with me for sacral colpopexy. So it's easy to use that same mesh, and that allows us to minimize the amount of mesh being put in. There's actually no solid data that I've seen yet showing that permanent is necessarily better than biologic. Although that being said, I have redone a lot of biologic ventral rectopexies. They had that done and now they're recurring, and they're around that 4 to 6 years out. So maybe that'll play out in the long run. But sewing biologic mesh also in the pelvis is somewhat tricky, because you can't see through biologic mesh and you can see through permanent mesh. So you can be a lot more specific about where you're placing your stitches and how much tissue you're incorporating.
The question came in, probably I'll expand on it. So Do you do deficography in all patients in fecal incontinence, or can you just go off a clinical exam or history? There's a, where I used to work, we didn't have deficography that was readily available. We'd have to kind of look for it, get it improved, and we're a little bit, sometimes pampered and blessed here at the Cleveland Clinic, having that ability to do it. So what do you say to the people out there? Is it a must, or is there places that you would say, really, it's nice, as you said, but what's your thought there?
Yeah, I've definitely seen, I have a lot of colleagues who do pelvic floor that they don't have deficography at their fingertips, and their algorithm then may be to actually go for sacral nerve stimulation. So if they don't see any obvious prolapse, they don't pick up any on their exam, then they may start with their test phase of sacral nerve stimulation. And if it doesn't work, then they try to seek out the deficography. So that's not a bad algorithm, it's not incorrect, but I am lucky enough to have deficography. I've done a lot of it in my career, so I feel very comfortable looking at it. And I think it scooped a lot of patients that I pointed down a very different treatment pathway than I would have if I had not had it. So I feel like I'm getting them to the right treatment first, or I'm ruling things out first.
So another question came in. Can you talk about a tibial nerve versus sacral nerve, the difference between the two, and when you use one versus the other?
Mm-hmm. So tibial nerve stimulation is a very high maintenance treatment option. I didn't include it because I personally have not had a lot of patients maintain compliance with it. You have to be seen 2 to 3 times a week to have this little needle kind of inserted to stimulate the tibial nerve. So it's more of a hands-on, I wouldn't say invasive, but not something that people are really attracted to going to do. I mean, if you've ever had a patient you say you have to go to pelvic floor physical therapy, they look at you like that's the worst thing that you've ever said to them. So then if you say, well, you're going to get to go to physical therapy and there may be this little bit of twinge of pain and you're going to sit there and we'll see how it works. And then trying to get them to comprehend how stimulating something in their leg is going to improve their continence is just, I've lost them at that point, even though there is data showing that it works. But it's really difficult to get patients to comply with that.
A quick question on deficography. Do you use oral or vaginal contrast or just rectal contrast alone?
So I use rectal contrast and vaginal contrast. And all the fellows I've trained who have gone out and they've been at a place that just had rectal contrast, I think I've successfully converted them to talk to their radiologist and give vaginal contrast too, because I think that's the only way you're going to really see what's happening in the anterior middle compartment, which is important to us to know how much that's collapsing on top of the rectum. And they can use oral contrast if you want to be able to see see if there's a small bowel NRCL. It's okay. I don't have strong feelings that has to be done, but it's not bad.
I have another question I have a patient that has a non-MRI compatible SNM. Should I replace this lead out to get an MRI?
Yeah, that's going to become a tricky question because the MRI compatible SNMs just came out in the last few months. So patients who need routine MRIs, maybe rectal cancer surveillance, breast cancer surveillance, I think there may be more urgency to doing that. It's not the battery. The battery has always been MRI compatible. It's the tined lead. So you have to take the whole lead out and put a new one in. I think just because it's here and it's available, I wouldn't start changing all those out. If it's working and they don't need an MRI, then just keep it working. But certainly in people who it's prohibiting them from getting tests they need, then it's a minor outpatient procedure and it can be easily replaced.
A couple more questions that have come in. So if sphincteroplasty results are that poor at 5 years, is there any role anymore for redo sphincteroplasty?
Mm-hmm. No. I don't know who would sign up for that one.
Rectal intussusception and medical therapy alone. You talked about the role for SNM or looking at that, but what about just medical therapy alone for rectal intussusception? Is there degrees of rectal intussusception?
Mm-hmm. There are, and you do have to be somewhat careful of rectal intussusception. I mean, if anybody strains hard enough, they'll intussuscept their rectum, right? And so when you look at the deficography, you do have to be able to look at that and say, well, did they push and everything fell and it just stayed there? It didn't kind of spring back up to a normal position. That would be a rectal intussusception that is a persistent anatomic defect, that there's no amount of medical management or implantable devices that's probably going to make that anatomy go back to normal.
Question came in. If you're not doing sphincteroplasty, do you really need to do a rectal ultrasound at all anymore.
Yep. No, I mean, I don't do a lot of rectal ultrasounds anymore.
Does it have any prognostic role in terms of how they respond to SNM?
Mm-mm. No, patients can have no defect or they can have a huge defect and they've had the same improvement with SNM.
We got a few more questions if you want to take some time to get in your last final questions on the chat line. That'd be great. Otherwise, we got a few more to end up. So ventral rectopexy and functional outcomes. I saw a wide range listed there. What do you tell your patients?
You have to decide what their symptoms are they want to have treated. It's far easier to treat fecal incontinence predominant symptoms with ventral rectopexy than it is the obstructive symptoms, because obstructive symptoms tend to have a component of constipation, so they still require some dietary modification. But in patients who really are more concerned about the seepage, ventral rectopexy is great. I've seen that almost completely resolve in most patients.
Somebody was confused a little bit about these temporary leads that you place in clinic. How does that work? And they leave sticking out of their back?
Yeah, they look a little bit like a walking palm, but you can't see it. So they're literally like the size of a piece of hair, these little peony leads that you put in, and then you just cover them with a tegaderm bandage, and they're hooked into the stimulator device, which is about the size of a quarter externally. So yes, if you saw their back, you would see these little wires that were kind of taped to their back. And I tell them probably not to fly or go through anything. Then they may have to answer questions during that 1 week test phase. But it can be done in clinic. It takes maybe 15, 20 minutes. So it doesn't require any operating room. And then there doesn't have to be this planned surgical schedule. So if we used to do the stage 1 in the operating room, which means you have to have something done at 2 weeks. You can't walk around with this hanging out of you. But when you do it in clinic, those little leads just kind of pull out. Commonly, I'll have the patients pull them out at 1 week, and we'll check in and see how their results were.
Yeah, probably not an easy conversation with the TSA agent that you're fecal incontinent. And then last question that came is could you talk a little bit about the status of the artificial bowel sphincters? What's going on with them? Are they on the market? Are they off the market? Is there any hope for them in the future? Ones that are going to work and not erode? What is that?
Mm-hmm. So I think the short answer is we have not been able to find one that is perfect, that beats any of the other treatment options that are out there. The one that is still a little bit around, although not right now, it's not on the market in the United States, are the little tiny magnets. It looks like a bead bracelet that goes in the Phoenix that will expand when they defecate and then go back. That still had a really high explant rate because of infections or erosion. So that was part of why it came off the market. And the other part, I think, was, the company was bought, sold. And so my feeling is now that sacral nerve stimulation is out and has such great results that people are just going away from the more invasive approaches of the artificial sphincters.
Well, that's fantastic stuff, Sarah, and we thank you so much for taking the time to join us here on our DSI Virtual Grand Rounds and talk about, again, a condition that is probably much more prevalent than we would even like to consider, and if it's affecting your patients, when they're coming to you, that can be truly debilitating. So just a few reminders. First of all, you can claim your CME credit up to 30 days. You can see the code listed right there. And for all of those who have registered, you'll be getting an email from Rita, who is our CME coordinator and our academic coordinator, to go over the process. If you have any questions, please feel free to respond to her, and she will be able to guide you through that process. And you will have presentation of today's handouts that will be emailed you to all attendees immediately after today's broadcast. And just another reminder, we're very happy that we can reach out to you and we can have a collaborative, interactive process through all of our virtual CME events. And as you can see listed here, we are going to continue on with our annual multidisciplinary colorectal oncology course that we normally have in the fall. We're going to do it virtually. Got a great lineup for you here, and please visit our CCF site for all of that, or contact Rita. She'll be able to give you all of the information on that. And then we are continuing on our COVID-19 live from CCF in every month. We have October, November, December, as you can see listed right there within our DDSI world, looking at everything from solid organ transplants or hereditary colorectal cancer. And lots of good things coming out. But if you have any problems or can't find out where that is on our websites, please reach out to Rita. She's got her contact listed right there, and she'll be able to interact with you. So, Sarah, thanks again so much for joining us here on our DDSI Virtual Grand Rounds broadcast. And to all of you from all around the world, have a great day.